Hello, welcome to Learn from the Case. How are you? Today we continue talking about migraines because in just one video it will be too long. This is the second of 5 videos. A stage of migraine or phases of migraine. Phase 1, prodrome. Premonitory symptoms associated with hypothalamus activation, dopamine. Around 77% of patients suffer prodromic symptoms for up to 24 to 48 hours before the headache onset. It is more common in females than males, 81 to 64%. Like yawning, mood change, lethargy, neck symptoms, light sensitivity, restlessness, difficulties in focusing vision, feeling cold, craving, sun sensitivity, sweating, excess energy, thirst, and edema. Studies of the premonitory phase have shown that the hypothalamus plays an essential role in the origin of a migraine attack, and this may eventually change the objectives in treatment, because considering what has been observed in different studies, signals are sent from the hypothalamus to the brainstem, where the so-called migraine generator is located, RAF nuclei and locus coeruleus. This generating center sets in motion the mechanism responsible for pain. If an effective way to influence these signals is found, perhaps the entire process could be interrupted before the individual feels the migraine itself and its associated symptoms. The dorsal RAF nucleus is a specific nucleus within the RAF nuclei that sends serotonergic projections to the limbic system and plays a role in regulating mood. The correlation between pain and visuospatial dysfunction with RBD, which is rapid eye movement sleep behavior disorder, is a parasomnia characterized by dream enactment behaviors that emerge during a loss of REM sleep atonia. Severity might be associated with RBD pathophysiology. This pathophysiology is currently poorly understood, but RBD is thought to be associated with several nuclei in the pontomedullary brainstem that include the locus coeruleus, subcoeruleus, sublateral dorsal nucleus, laterodorsal tegmental nuclei, the PPM, and medullary magnocellular reticular formation. These nuclei play a role in pain modulation, visuospatial attention, and cognition, including visuospatial function and memory. The locus coeruleus is a norepinephrine-producing nucleus in the dorsal pons and projects to the brain widely and is involved in homeostasis, sensory processing, and cognitive and motor function. The RAF nuclei are serotonin-producing nuclei in the midline from the medulla to the midbrain and are also involved in sensory processing that includes pain, heat, touch, and visual orientation. It is observed by many patients and caregivers of these migraine sufferers that there is a connection between migraine and sleep disorders. But I don't want to go into this explanation too much, into what is now known and theorized about hypothalamic activation, dopamine, and reticular formation, which its nuclei in the pathophysiology of migraine, but I wanted to mention it a little here. Let's continue. The phase 2, aura. Changes in cortical function, blood circulation, and neurovascular integration occur in about 25% of cases. Visual auras are the most frequent ones. Can precede the headache, or it can present simultaneously, typically gradual, less than 60 minutes in duration, more often visual, and have positive and negative symptoms. And what do I mean with positive symptoms? Positive symptoms are caused by active release from central nervous system neurons, bright lines, or shapes, or tinnitus, noises, paresthesias, allodynia, or rhythmic movements. Scintillating scotoma is typical, is the most common. Then negative symptoms. Those indicate a lack or loss of function, reduction or loss of vision, hearing, sensation, or motion. The most common negative visual symptom is visual field defects. Then the third phase is migraine attack. The fourth phase or stage is post-DROM, persistent blood changes with symptoms after the headache termination. This phase consists of a moment vulnerable pain in the same location as the previous headache. Common symptoms can be exhaustion, dizziness, difficulty concentrating, and euphoria. Evaluation. What a doctor is going to ask and look in a patient with migraine. Demographic feature of the patient as usual: age, gender, race, profession. When did the headache start? Where does it hurt? Location, irradiation. What is the intensity of the pain? How is the pain? Which are the qualitative characteristics of pain? How long does the pain last? At which moment of the day does the pain appear? How has it evolved since it started? What is the frequency of appearance? What are the triggering situations? Simultaneous symptoms. Is it related to sleep? How does it get better or worse? Which medications does the patient take to make it better? What is the frequency of this medication? Patients should also be questioned about somatosensory disturbances, such as spreading unilateral numbness or tingling in the face and arm, as well as about disturbances in speech or thinking, some aura symptoms that could indicate uncommon types of migraine: motor weakness, dysarthria, hypoacusia, diplopia, ataxia, vertigo, tinnitus, decreased level of consciousness, abnormal neurologic examination, especially if there are unexplained symptoms or signs: confusion, stiff neck, papilledema, epilepsy. Non-typical characteristics: changes in the patient's typical features or patterns, new episodes in older onset in people that is over 50 years of age, or onset in immunosuppressive patients, systemic or meningeal signs or symptoms: fever, weight loss, fatigue. New neurological symptoms or signs on examination: headache not responding to treatment, headache lasting more than 72 hours, a significant change in the frequency pattern or severity of headaches, severe headache pain, worst headache of life, or headache causing awakening from sleep. New onset headaches in patients with HIV infection or patients with cancer. Associated symptoms or signs suggestive of meningitis or stroke. The commonly used acronym SNOOP can be used to aid in the determination of neuroimaging indications. S for the systemic signs or symptoms and secondary risk factors. N for neurologic signs or symptoms. O for onset. O for older. P for position-dependent intensity changes. The prior pattern changes, papilledema, and precipitated by Valsalva maneuvers. Cerebrospinal fluid analysis and electroencephalogram are not typically performed unless seizure activity or infection etiology has to be excluded. Differential diagnosis. The following should be considered in a patient with a migraine: tension type headache, cluster headache, cerebral aneurysm, chronic paroxysmal hemicrania, dissection syndromes, encephalitis, subarachnoid or other intracranial hemorrhages, meningitis, temporal or other giant cell arteritis. Tension type headache is usually bilateral, lasting 30 minutes to 7 days. The patient feels pressure or tightness but remains active. There are no associated symptoms. Cluster headache is unilateral and has a sudden start around the eyes or temple. It progresses in intensity between minutes to an excruciating, continuous, deep pain. It lasts 50 minutes to 3 hours. Associated symptoms include lacrimation and redness of the eye, rhinorrhea, pallor, sweating, Horner symptoms, agitation, and focal neurologic symptoms. It can easily be provoked by alcohol consumption. And here we leave it now. As always, I want to invite you to leave me your comments if you have something to add or if you have something to ask. The next video on migraines will come with more information soon. Thank you for your attention and stay very, very well.